Okay, is my screen visible?
Yes.
Okay. So today we're going to discuss a very important topic, adrenal insufficiency. We'll be discussing the basics of the same. We'll also see how we often miss out adrenal insufficiency. It's a very important condition, often life-threatening, and in fact, it is much more common than we think. Like I said, it is often missed out in clinical practice. So that is what we're going to discuss. We'll see it from the perspective of various cases, kind of some real life cases that we have seen over the past few years. So let's start with a few cases and then we'll go into the clinical and the theoretical aspects of it. So let's take a case. So this is very interesting. This is very similar to a patient which I saw just today. So this is actually an old case. This is a 40-year-old male patient who was from Haryana. He presented with hypertension, weight gain, and erectile dysfunction. So this is the patient. You can see very clearly. Now what you can see here is a typical case of Cushing syndrome. You can see the moon-like faces in this here. You can see the Cushing-like stria, right? Here also you can see the stria. So this is a very typical patient of a Cushing syndrome. How do we say this is a moon-like face? When you say patient is having moon-like face, you see the patient from the front, and if you're not able to see the ears from the front side, that is what is known as a moon-like face. That is the temporal fat deposition. So if you have a temporal fat deposition, this is important for postgraduates. So important, if you have a temporal fat deposition, that's what is described as a moon-like face. So this patient had a typical features of Cushing syndrome. Now you'll be wondering why we are discussing Cushing's in the lecture of adrenal insufficiency. Well, the answer really comes from this is another patient. You can see the typical Cushing-like stria and moon-like face. You can see the flush also, facial flush, very typical red hue in this patient, very classical. So why are we discussing this case? Because both these patients, which you saw, the pictures you saw, are iatrogenic Cushing syndrome, right? We'll discuss Cushing syndrome as a separate lecture in a future lecture series. But these patients were having what is known as iatrogenic Cushing syndrome. So these patients were on steroids, right? Now, what kind of steroids they were taking? Generally, they'll be taking some form of a steroid for a long period of time. Now, the steroid could be given often for many reasons. But most of these patients were from rural areas, and there are a lot of quacks, a lot of quackery, and a lot of the times patients go to not so qualified doctors with complaints of generalized weakness, fatigue, and in all these situations here, they are given dexamethasone. It's very common practice. And there's often patients have feeling of well-being with the use of dexamethasone, and they often take this recurrent injections, often by going to the doctor. Sometimes they don't even go to the quote unquote doctor, and they take these injections themselves, right? So in fact, both these cases were on dexamethasone. Another patient that I saw today was on prednisone, methylprednisolone, Zempred 4 milligram, taken at bedtime. He had recurrent itching, and somebody said that isse itching theek ho jayega tumhara. The patient actually had relief from itching with Zempred, and the patient had been taking Zempred for the last 4 years until we went to a dermatologist for the skin changes, and dermatologist diagnosed this patient as having Cushing's, iatrogenic Cushing's. So again, I'll tell you why iatrogenic Cushing's is very important from adrenal insufficiency point of view. So what we did in these patients was we did a simple 8 a.m. cortisol in the morning, and the value was 1.2 microgram per deciliter. Now I'll discuss the interpretation of these values as we go along, but to tell you at this point of time that this value is very low. This is definitely low. So when you see a patient who looks Cushingoid, but the cortisol value is actually low, baseline cortisol value is low, you have to think of iatrogenic Cushing's, and iatrogenic Cushing is the most common cause of Cushing syndrome in India, without a doubt. In fact, in the world, right? The most common cause of Cushing syndrome is iatrogenic Cushing's. So this is something very important, and this iatrogenic Cushing syndrome has associated tertiary adrenal insufficiency. Like I said, why this is important? Because not only is exogenous Cushing or iatrogenic Cushing the most common cause of Cushing syndrome, but what I've experienced in my practice, and a lot of people would say the same, the most common cause of adrenal insufficiency is also tertiary adrenal insufficiency because of long-term steroid use. Now, in some of the cases, steroid may actually be for some particular reason where it could be prescribed. For example, post-transplant patients, the patient would be on steroids for a long period of time. Patients with certain rheumatological conditions, SLE or something like that, patient would be on steroids. Patient with recurrent COPD requiring recurrent steroid injections. In fact, it is also said that inhaled steroids, as you give in patients with COPD or asthma, also can lead to tertiary adrenal insufficiency. This is all very important. So again, as physicians, we often deal with perioperative patients. So let's say this patient comes to you for joint replacement, or patient develops a fracture. Now, exogenous Cushing's patients are more likely to develop fractures. So let's say patient develops a fracture and patient comes in an emergency and they want a perioperative fitness from a physician. It's very important that these patients are treated as having tertiary adrenal insufficiency until we prove it, and given glucocorticoids perioperatively, because at this point of time, this patient would have increased physiological demand for glucocorticoids, which will not be matched by patient's own endogenous production. So this is very important from a physician's perspective. That's why this case we started with right at the beginning, that exogenous Cushing syndrome and tertiary adrenal insufficiency is one of the most common cause of adrenal insufficiency, often missed out in clinical practice. And if this patient goes for surgery without a perioperative steroid cover, the post-operative consequences may not be that good. So this is something we need to be very well aware, and we need to be very well aware about this condition. So what is basically adrenal insufficiency? It is basically inadequate glucocorticoid production by the adrenal gland, that is adrenal insufficiency. Now this could be because of three major reasons. So this is the hypothalamic-pituitary-adrenal axis. So you have the environment, which environmental stress or any other environmental factor, which acts on the hypothalamus. The hypothalamus produces corticotrophin releasing hormone CRH, which acts on the pituitary gland to produce ACTH, and this ACTH acts on the adrenal gland to produce cortisol. So this is the hypothalamic-pituitary-adrenal axis, the HPA axis, a very, very important axis. In fact, our life depends on this, right? So if anything, your life actually depends on this axis. Now, what is primary, what is secondary, and what is tertiary adrenal insufficiency? This is what it is. So primary adrenal insufficiency is what is known as Addison's disease, is when you have disease of the adrenal gland. Secondary adrenal insufficiency is when you have disease related with the pituitary gland. And tertiary adrenal insufficiency, as we saw in the cases earlier, is when you have problem with the hypothalamus. So if you have a patient on glucocorticoids, on steroids for a long period of time, the entire axis, this entire HP axis is suppressed, and the suppression often comes from right from the hypothalamus. So hence this is known as a tertiary adrenal insufficiency. Again, primary adrenal insufficiency, we'll see the various causes at a later in the course of the lecture. We'll see, in fact, the etiology in the course of the lecture. So we'll come to that in a minute. But the point is that adrenal insufficiency can be primary, secondary, and tertiary. And if you see overall in terms of another classification of adrenal insufficiency, you can classify adrenal insufficiency as either primary or central, right? And central adrenal insufficiency is again could be both at the level of pituitary or at the level of hypothalamus. So this will be primary, this will be secondary, and this is tertiary, right? So this is adrenal insufficiency. So what do glucocorticoids do? So when you give glucocorticoids from outside, they suppress both the ACTH production by the negative feedback as well as the CRH production. Hence, this is often known as the tertiary adrenal insufficiency because there is block at the tertiary level. Now, similar picture can also happen when there is damage to hypothalamus, which can happen secondary to perhaps a pituitary or a suprasellar surgery. In that cases, also you'll have a tertiary adrenal insufficiency, but the most common cause often is exogenous glucocorticoid use. Okay, so moving ahead, when do you suspect a tertiary adrenal insufficiency? So when should you suspect a patient having tertiary adrenal insufficiency? Now, patient taking medications often from quacks for diseases like arthritis or asthma or COPD or PO. When you have some adulterated medications, often you don't know what the patient has, and most of the times, a lot of the times when the patient says that mera asthma tha aur theek ho gaya, think of glucocorticoids being given to the patient. Patient would be on glucocorticoids unless food otherwise. So if you have a patient with history like this, so again, when you're taking history before in a perioperative situation, perioperative patient, this is something you should be looking for. Patient who appears Cushingoid at baseline, but baseline cortisol is low, like we saw in the cases earlier. This again is also patient having tertiary adrenal insufficiency. Sometimes symptoms may be more subtle. So sometimes patient may have just mild complaints of weight gain, fatigue, recurrent fractures for no reason, suddenly develops hypoglycemia, right? Or patient has hypoglycemia which is unexplained. Sometimes, patient has low sodium, hyponatremia. We'll discuss hyponatremia. It's very, very important in this situation. So all these things can lead to tertiary adrenal insufficiency, and this is something we need to be very important and we need to be aware. And history taking is very, very important for these cases. So we need to be well aware of this. Now, what are the subtle cases where you should suspect adrenal insufficiency, tertiary adrenal insufficiency? So when you have unexplained weight gain, when you have skin changes, stria, facial flushing, thinning of skin with bruises. Sometimes, patient at the site of blood collection, patient has bruises. Again, this is something this is very often we see this. We in fact picked up a lot of cases with tertiary adrenal insufficiency with just this fact. They have bruises. They have unexplained osteoporosis or vertebral fractures. They have unexplained hypoglycemia or even hyperglycemia. So sometimes, patient was on glucocorticoids from some quack and then it was stopped, so develops hypoglycemia. Or patient suddenly develops, high blood sugar, taking some treatment from some local doctor and blood sugars are high. And unexplained hyponatremia, this is very, very important unexplained cause of hyponatremia. You need to consider adrenal insufficiency as a cause. This is, like I said, very important. We'll discuss the point of hyponatremia in a minute. Now, how do you manage a patient with tertiary adrenal insufficiency? We obviously need to give low dose of glucocorticoids. You need to give glucocorticoids till the HPA axis completely recovers. And this recovery of HPA axis may take a long period of time. Sometimes it may take months to years, right? So sometimes anywhere between 9 months to 1 year, sometimes even longer. Depends on what steroid the patient was taking, how the patient was given the steroid, what dose, what route. All these things are very important, and all these things would impact the HPA axis. And then you of course need to treat any complications arising from the exogenous glucocorticoid use. For example, let's say the patient develops osteoporosis, so you need to treat the osteoporosis. So all these things are very important from the treatment perspective in tertiary adrenal insufficiency. Let's look at a second case. So this, I think we discussed a little bit about a similar case in the last chapter as well. I think in the last lecture as well about hypothyroidism. Now, this is a case of a 61-year-old female presenting of weakness and fatigue for a long period of time. Somebody ordered a TSH which claimed to be mildly elevated. Now, this patient was on a low dose of levothyroxine. The patient continued to have fatigue, weakness, anemia, etc. So we took a detailed history of this patient. The patient had a history of a postpartum hemorrhage 23 years back in her last delivery. She also had subsequent amenorrhea and lactation failure. So if you had attended the last lecture, you probably would have already thought and maybe reached to your diagnosis in your mind. So what we did was we actually stopped the levothyroxine. We sent a morning cortisol level and ordered a complete thyroid function test, and the baseline cortisol was low. It was again something around 1.2, 1.3, and thyroid function test was suggestive of central hypothyroidism. So if you can recall from the last lecture we had, when do you think of a central hypothyroidism? Think of a central hypothyroidism when you have free T3 and free T4 which are low, And TSH can be mildly, can be low, can be normal, or mildly elevated. And if you remember from last lecture, the elevated TSH is typically less than 20. Most cases less than 10, but sometimes even less than 20. So if you have a picture where, let's say, free T4, let's say the normal lower limit is 0.8 value. Let's say the patient has 0.6 free T4 and TSH is 6, right? So in this case, don't think of subclinical hypothyroidism, but rather think of a central hypothyroidism, right? So this is a typical thing you need to understand. And remember, when you have a central hypothyroidism, you should also rule out adrenal insufficiency. This is very, very important from a physician's perspective. Okay, so this case, what this patient had was what is known as a Sheehan syndrome. And this is a form of secondary adrenal insufficiency. So secondary adrenal insufficiency, as we said, the problem lies at the pituitary gland. So this patient had a secondary adrenal insufficiency with the disease at the pituitary gland. If you see this patient's MRI, what you can see here is a empty cella. You see here is an empty cella. So the pituitary gland, which should be here, is missing. You can see a thin rim of pituitary gland. So this you see here is the thin rim of pituitary gland. This is the typical patient having an empty cella. So this is a very important secondary adrenal insufficiency. When should you suspect a Sheehan syndrome, especially in females? So you should have typically a patient presenting with low T3, low T4 with normal, high or low TSH, as we discussed in the last lecture. Patient with history of severe postpartum hemorrhage, right? This is an important history which should be taken. Patient having history of lactational failure and amenorrhea, prolonged amenorrhea after the delivery, and secondary amenorrhea persisting after the delivery. So in this situation, you should think of a secondary adrenal insufficiency, or rather Sheehan syndrome should be suspected. Sheehan syndrome is not uncommon in India and has to be thought of and diagnosed. And again, it's very important to understand that unexplained hyponatremia and hypoglycemia. Again, this is where you should suspect Sheehan syndrome, as we had already discussed in the earlier. In fact, we had one more patient with Sheehan syndrome who presented with recurrent hypoglycemia. We had another patient with pan-hypopituitarism presented with recurrent hypoglycemia. So a lot of these patients, often can present with hypoglycemia. So that's something you should be, careful. And if you see, I've shown the picture of this patient. These patients typically have a pale, listless face, ghost-like face. Right? So if you've seen a patient with Sheehan, you'll not forget. This is a very typical classical clinical picture, photo of this patient, or a typical, face of this patient. If you see, it's a ghost-like face. This is very typical of Sheehan syndrome. So if often you see this patient and you suspect Sheehan's straight away, you will often have an empty cella on the MRI. So this is the second case, which was a secondary adrenal insufficiency. And let's look now at a case of a primary adrenal insufficiency. Okay. So let's see the case here. So this is a 57-year-old male patient who presented with history of fever, vomiting, loss of consciousness, and an evaluation. This might be. Let's see this case. So this is not a primary adrenal. This is. Let's see this case. So in emergency, patient presented with hyponatremia. Again, I'm repeating, hyponatremia and hypoglycemia are very important clinical signs and symptoms of adrenal insufficiency, should not be missed. So patient with unexplained hyponatremia, unexplained hypoglycemia, think of adrenal insufficiency. So this patient's sodium was 129 in emergency when we saw, and the prior, the patient had 1 month back had general checkup where the sodium was 135. So there is definitely a fall in sodium. Now, patient had history of similar illness in the past when hyponatremia was recognized. So patient had repeated episodes of hyponatremia, which nobody had made the diagnosis. The patient's daughter noted that whenever this patient had fever, the patient would develop hyponatremia and this clinical picture. Right? Now, the patient was also known case of hypothyroidism for which he was taking levothyroxine. So again, something you need to keep your eyes and ears open. So we sent a matching sample. So now we are seeing this from a perspective of hyponatremia, right? So we send a matching sample for serum osmolarity, serum sodium, urine osmolarity, and urine sodium. So this typical 4 samples that we send for evaluation of hyponatremia. We send this. and we gave a bolus hypertonic saline 3%. And after giving that, the patient did regain consciousness by the sodium raised to about 5 millicuries per liter. Remember, sodium should typically raise by 8 to 10 millicuries per liter in 24 hours. Okay. So we reviewed the patient's history, and the important history was patient had history of pituitary surgery about 1 year back for a non-functioning pituitary adrenal. Now, this is again a very important history. So again, in this situation also, you are dealing with a patient who has a secondary adrenal insufficiency, right? So then the endocrine consultation was solved, and then we saw this patient's report. So these are the patient's reports. So patient's sodium is definitely having hyponatremia. This is hypoosmolar, right? So the osmolarity typically it's 290s, right? 290 to 300 is typical osmolarity. This is low. The urinary sodium is 40. The urine osmolarity is pretty much, okay, and patient is otherwise euvolumic. So this is a euvolumic hypotonic hyponatremia. And euvolumic hypotonic hyponatremia, three differential diagnoses you have to consider. One is adrenal insufficiency, second is hypothyroidism, and third is SIDH. So these three differential diagnoses. Remember, SIDH is a diagnosis of exclusion after ruling these two things out. So if you rule out adrenal insufficiency and hypothyroidism, you have to then only consider the diagnosis of SIDH. So if you see this hyponatremia chart, right? How do you evaluate a patient with hyponatremia? Hyponatremia, I repeatedly am saying, has a very strong relation with adrenal insufficiency, and hence it is something you need to look at. So you see a patient with hyponatremia, the first question you ask is the patient dehydrated? If the patient is dehydrated, is the urinary sodium more than 20? Is the patient losing sodium? If the patient is losing sodium, if you can see here, the urinary sodium is 40. Right? So patient is losing sodium despite, of course, this patient was euvolemic, but if the patient is is dehydrated and continues to still lose sodium, because in a normal situation, if there is normal dehydration, then the sodium should be retained. But in this case, the patient is losing sodium. Again, you should think of adrenal insufficiency. Otherwise, if the sodium is not more than 20, urinary sodium is not more than 20, you think of the other causes of loss of sodium, cause of dehydration and hyponatremia, that is diarrhea, vomiting, etc. Now, if the patient is not dehydrated, see if the patient is edematous, if the patient is hypervolemic, right? If the patient is hypervolemic, think of heart failure, cirrhosis, renal failure, etc. If the patient is not having heart failure, think of other causes, and then look at urine osmolarity. If the urine osmolarity is more than 500, think of SIDH, but if it's not, then think of other causes like hypothyroidism and adrenal insufficiency. But again, I'll repeat, the SIDH also is a diagnosis of exclusion. So even if you think of SIDH, think of these two conditions first before you rule out before you diagnose SIDH. So in this case, typically you can see urine osmolarity is 300. So everything points towards this direction, right? You can see over here. Okay. So again, this is like, hypotonic hyponatremia. We're able to enlarge it. Okay. So again, similar, flow chart. But the point I'm trying to make is when you have a euvolumic, right? Or even in case sometimes, adrenal insufficiency patient may also be dehydrated. So euvolemic or hypovolemic hyponatremia, think of adrenal insufficiency is an important cause. It's a very important cause of hyponatremia, and hence must always be considered as a differential diagnosis whenever you're dealing with a patient with hyponatremia. This is a very, very important situation that you have to understand. Right. So in this case, when you have a euvolemic hyponatremia, think of adrenal insufficiency, hypothyroidism, SIDH as potential causes. Right. So adrenal insufficiency is a very, very important cause of hyponatremia and should always be diagnosed and should not be missed out. One very important, now a little bit about primary adrenal insufficiency. We discuss the tertiary and secondary, but very important thing which defines primary adrenal insufficiency is they have hyponatremia with hyperkalemia, but a secondary, right? So we had seen this flow chart earlier. So you have primary and you have central causes like secondary or tertiary. So one very important differential straight away from this situation is primary adrenal insufficiency, sodium will be low in both the cases, But here the potassium will be high, whereas in a central adrenal insufficiency, the potassium is often normal or sometimes even low. Especially if the patient is on something like a dexamethasone or something, the potassium has been taking dexamethasone for a long time, and sometimes potassium may be low, right? So this is a very important, again, something which is common misconception that adrenal insufficiency always has hypokalemia. No, it is not true. Adrenal insufficiency has hypokalemia only if it's primary adrenal insufficiency. In secondary or tertiary adrenal insufficiency, you generally tend to have normal or sometimes even low potassium, right? So this is the point which is we are trying to make. Okay, this is important. Okay, now why does adrenal insufficiency produce hyponatremia? So we'll discuss this as a point. Now we know this thing from the pituitary. So we already discussed that CRH from the hypothalamus acts on the anterior pituitary to produce ACTH. So CRH produces ACTH, which produces cortisol. Okay, and then there is negative feedback, right? So there's negative feedback here and there's negative feedback over here. But one important also associated axis we often forget is that the antidiuretic hormone ADH also acts on the pituitary. So ADH acts on pituitary to produce ACTH. Remember, ADH is a hormone of posterior pituitary, but it is released by posterior pituitary, but it is not produced by posterior pituitary. It is actually produced by hypothalamus. So ADH, also known as AVP, right? The ADH or AVP also has positive impact on ACTH, as also has positive impact on cortisol, and the negative feedback is also there here as well, right? So cortisol not only inhibits CRH, but it also inhibits ADH or AVP. So it also reduces the of the antidiuretic hormone or the AVP. This is a very important and often missed out concept. This is in fact not even taught very well in normal physiology, right? So this is a very important concept, and in fact in clinical practice this is what we see very commonly. Right? So what happens as a result of this? So when you have a cortisol deficiency, remember, if you have a cortisol deficiency, there is this negative feedback goes away, and hence there is reduction of ADH, increase of ADH secretion. And increase of ADH is what is increase of ADH? SIDH, right? Inappropriate ADH secretion. So technically speaking, adrenal insufficiency is a form of SIDH itself, right? So AI itself, adrenal insufficiency itself is a form of SIDH. Hence, a very important differential diagnosis when you have a patient where you're suspecting SIDH is adrenal insufficiency. I think, I stressed enough of this, and this is a very important point here. Okay. So this is the point I was trying to make. So if your cortisol is low, the ADH is high, and you tend to develop hyponatremia as a result of that. Okay, so let's look at another case, right? So this is the same case, right? So we looked at this situation, right? So this patient's cortisol was 6 microgram per deciliter. His free T4 was low and TSH was normal. So this again is central hypothyroidism. But what about the cortisol? Okay, so cortisol normal lab range was mentioned as 3 to 15. So you would tell me that normal range 3 to 15 chair, or if this is the range and the cortisol is 6, isn't this normal? Well, what you have to understand is that this is again a very important concept which we all need to understand, is that whenever you are assessing the patient's cortisol, or whenever you are assessing, in fact, any endocrine system, you need to see it from the clinical context. Now, if you remember this patient came in emergency with hyponatremia, with altered status, with fever. In normal situation also, so patient would have some endogenous cortisol production, and some bit of ACTH production. And what happened in this patient was, patient's body was trying to produce more cortisol, but ideally in this situation the patient would require much higher cortisol value, but it is not able to produce the amount which is required. So the cortisol is though technically in a normal range. For this physiological state, the patient's cortisol is actually not normal. Hence, in such situations, whenever you have cortisol which is between, we'll discuss this as we go along, but when you have a cortisol where you're suspecting adrenal insufficiency, but the baseline cortisol is quote unquote normal, in this case you have to do what is known as a ACTH stimulation test. So this ACTH stimulation test, we did this. In this case, the ACTH stimulation test, the post-stimulation value was 10, which is low. It should be more than 18, right, which is not seen in here. So this patient has, again, adrenal insufficiency, just to confirm the diagnosis. Right. So some other practical aspects of assessing the HP axis, right? We'll discuss this. Important. Before that, I think, 1 second. We had one of primary adrenal insufficiency, which, yeah, this is case 4. Okay, so we'll come back to this practical aspects in a minute. We'll discuss this 4th case first. Okay, so okay, let's look at the 4th case. So this is a typical case of a primary adrenal insufficiency. I think we'll invoke this case in our last presentation also. So this patient actually is a 22-year-old and we have the participants on mute. Second. Okay, so this is a patient with, here I'm going to demonstrate a case of a primary adrenal insufficiency. This patient had history of weight loss about 15 to 18 kgs, and had generalized fatigue and darkening of skin. Now comes a very interesting clinical point, and darkening of oral mucosa over a period of 1 year. Right. So if you see this is the patient. Right. So you can typically see the darkening of skin here. You can see some skin creases. You can see. You have to see at the the underside of the the lips. You can see a little bit of darkening here. Right. So this is a patient who actually presented in to us. This is the case which we had reported. So prior to the admission, patient was admitted thrice in a span of 1 year with repeated history of vomiting and diarrhea, and was found to have hypotension each time. The third admission was patient was suspected to have some thyroid disorder by the physician who saw, and thyroid function test was done, and as expected, that there was a mild in fact, the overt hypothyroidism. Patient was started on levothyroxine, as most cases you would do this, right? But what happened was, once the patient was started on levothyroxine, the patient actually felt worse and developed syncope hypotension, for which he came to the emergency department. So when he came to us, actually, this patient had a classical textbook picture, as you saw from this picture. This is, of course, after the patient became better. He still says confusion in his picture. Very interesting, right? Okay, so this patient had a classical textbook picture of primary adrenal insufficiency, and he was actually in a state of adrenergic crisis. Okay, so if you see again the patient's investigation at the time of admission, again you can see here hyponatremia, and now we are suspecting primary adrenal insufficiency. The patient had hyperkalemia. You can see the patient's ACTH very high in thousands. Right, the TSH was, remember, he was on treatment. Yeah, but still the TSH was 16. Still it was high. The NTTP antibody was positive. Cortisol value was very low, 0.68. Right, and we of course did not do a ACTH stimulation because it was already very low, so in fact did not require. And then we started the patient on hydrocortisone. At the time of discharge, the patient's electrolytes improved in this case, right? So this is the typical case history. So what this patient basically had was primary adrenal insufficiency. He had what is known as APS2, so autoimmune polyendocrine syndrome type 2, which is basically, there are 4 types of APS, the different classification, but APS2 is something which we see in adults very commonly. And APS2 is adrenal insufficiency with either autoimmune thyroid disease or type 1 diabetes. So this, again, this type of picture you can see in patients with type 1 diabetes also. So this patient had what is known as a autoimmune polyendocrine syndrome. Now, if you remember last time, I told you that if you have adrenal insufficiency with hypothyroidism, you need to correct the adrenal insufficiency first before you treat the hypothyroidism. And we'll come to this point again. Okay, so what are the clinical features? What are the features of glucocorticoid deficiency? So when you have a patient with primary adrenal insufficiency, you have both glucocorticoid deficiency as well as mineralocorticoid deficiency. Another very important differentiating feature between primary and secondary or tertiary. So in primary adrenal insufficiency, you have both glucocorticoid as well as mineralocorticoid deficiency, whereas in secondary or tertiary, you just have glucocorticoid deficiency. So what are the clinical features of glucocorticoid deficiency? So glucocorticoid deficiency often produces GI symptoms like nausea, vomiting. Patients can have hypoglycemia, often fasting hypoglycemia, fatigue, weakness. If it's a child, then it could be failure to thrive. Patient could have morning headache and reduced free water clearance. But what are the features of mineralocorticoid deficiency? These patients can have hypotension, syncope, dizziness, dehydration, salt craving, muscle weakness, can in fact even have severe myalgia, in fact myopathy type picture also. Patient can have weight loss, patient can have GI symptoms. Again, GI symptoms could be because of mineralocorticoid deficiency also, and electrolyte imbalance. So these are all features of mineralocorticoid deficiency. So generally speaking, hyponatremia that you see in adrenal insufficiency is because of both glucocorticoid as well as mineralocorticoid deficiency, but the hyperkalemia that you see in secondary adrenal insufficiency is mainly because of mineralocorticoid deficiency. So this is a very important point, right? So again, if you see in terms of how differentiation between primary adrenal insufficiency versus secondary or tertiary, few things you have to see here. So you see, first of all, the sodium. Sodium is low in both the situations, but potassium, if you see, patients often have hyperkalemia, but here the potassium will be normal, sometimes even low. Thirdly, if you see in terms of deficiency, these patients have glucocorticoid as well as mineralocorticoid deficiency, whereas these patients only have glucocorticoid deficiency. And very important clinical differentiation, skin color. And these patients have dark skin, they have darkening of skin and oral mucosa, whereas this patient will have normal. In fact, the skin may be whiter, right, paler, right? So this is some clinical differentiating factor between primary versus secondary or tertiary adrenal insufficiency. And if you see in terms of lab reports, if you see ACTH will be high. Here, in this case, it may be normal or low. So this is typically how you differentiate primary and secondary or tertiary adrenal insufficiency. Okay. Now, why is the skin dark? The skin is dark, right? And this is again a postgraduate question. Why is the skin dark in patient with primary adrenal insufficiency? The skin darkening is because of ACTH, right? So what happens is, remember, there is another hormone in the body called MSH, melanocyte stimulating hormone. This acts on the melanocytes on the skin to produce dark pigmentation, right? So this produces dark pigmentation, and this MSH is released by there is the anterior pituitary and there is posterior pituitary, but there is intermediate pituitary also, from where MSH is being released. And this MSH and ACTH are very similar in their structure. So when ACTH levels are very high, it acts on the melanocortical trophic, the melanocyte receptors, leading to picture which is similar because of MSH, and that leads to dark pigmentation. So any condition that leads to increased ACTH will lead to dark pigmentation of the skin. And this is, again, like I said, a very important thing for postgraduates to understand. Okay, so far we have discussed the clinical features and we discussed 4 cases with primary, secondary and tertiary adrenal insufficiency. But now we'll go to the nitty-gritties of how to establish the diagnosis of adrenal insufficiency and how do you treat these patients, right? So in fact, we'll be focusing more on diagnosis. Treatment is very straightforward. Treatment is simple, right? You need to give steroids, but how do you establish the diagnosis? So let's start this step by step. So this is a protocol which we have developed. This is my protocol, right? So you can follow this, copy this, you take a screenshot of this if required. Most of these things are evidence-based, what you see here, right? So you're going to see an evidence-based picture. So when you have a patient where you're suspecting adrenal insufficiency, the first thing you do is you send a baseline reports of cortisol and DHEAS, which you send in the morning fasting. Okay, typically at 8 a.m. in the morning, right? So you send a morning sample of cortisol and DHEAS. Now, if the value of cortisol and DHEAS is less than 5, then this definitely means that the patient has adrenal insufficiency or the HPA axis is compromised. If it is between 5 to 12, then you see further. If it's more than 12, it kind of rules out adrenal insufficiency. Now, just to give you a caveat at this point of time, right? There is a new paper which has said that the cortisol, baseline cortisol more than 8 also generally rules out adrenal insufficiency. So baseline cortisol of more than 8, right, more or less rules out adrenal insufficiency. This is a new paper, but again, this is a recent data. We still go by this. So let's stick to 12, right? But then there's a new paper said that you can even bring that cutoff down to lower value, and if it's more than 8, generally it should be considered normal. But remember, you have to interpret again in the context of the clinical picture. So if the patient is having physiological stress, patient is in ICU, then value of 8 is definitely not normal, right? So it is definitely low. So, but this is an outpatient, right? We're dealing with an OPD patient. So in an OPD patient, when you have cortisol less than 5, it is adrenal insufficiency. It is 5 to 12. You have to look further, and if it's more than 12, it is generally considered more or less normal. Now, what happens when the values are between 5 to 12? So in this case, you have to calculate what is known as a DHEAS ratio. So DHEAS ratio is the, remember when the first test itself we had, so if you had seen in the first sample itself, we had sent a DHEAS. Now, what is the importance of DHEAS? DHEAS is basically, if you see the adrenal gland, right? So you have the GFR, right? Glomerulosa, fasciculata, and reticularis, right? So you have the 3 layers of the adrenal gland, right? And of the 3 layers, you have the the cortisol which is produced, right, by the adrenal cortex outside, right? Fasciculata and reticularis produces DHEAA, and which gets converted to DHEAS. Right now, the important point in this situation is that the DHEA and DHEAS, why are they important? Because these are also acted upon by ACTH. So these hormones are, so just like, so what happens is when you have ACTH, it acts on the adrenal and it increases the production of the cortisol as well as the DHEA. But why DHEA is useful? Because this has a long half-life. Right? So the cortisol has a short half-life, but this is long. So it is like something like checking the blood sugar or the blood glucose and the HbA1c, right? HbA1c or something like a fructosamine or glycosyl, right? Which gives you a glycemic status for a long period of time. Same way, a DHEAS gives you the status of the adrenal axis over the past 2 weeks. So it gives you a longer duration of the assessment of HPA axis. Hence, it is a very useful test. Sometimes, like I said, for momentary, there might be changes. Let's say the patient has taken steroid just yesterday, right? So then the cortisol will be low. But DHEAS will actually give you the picture over the last 2 weeks, right? So this is, hence DHEAS is useful. So what you can do is you can calculate the DHEAS ratio. So when you see a DHEAS report, the DHEAS report will have the normal value for the particular age of the patient. And what you have to see is you have to see the lower limit of the lab report, right? And this lower limit of the lab report, so the patient's value divided by lower limit of the patient's report, you calculate what is known as a DHEAS ratio. This DHEAS ratio, if it is less than 1, it is suggestive of compromised HPA axis. If it is between 1 to 1.8, you need to consider doing a ACTH stimulation test. If it's more than 1.8, it will tell you that the HPA axis is normal. So this is the second step for the diagnosis of adrenal insufficiency. And the third step, what you do is you use the ACTH stimulation test. So you go through stepwise, and if you reach the situation where you're still not able to make a diagnosis, then you do a ACTH stimulation test. I'll tell you the protocol for that. And if ACTH stimulation post-stimulation, if the cortisol value is less than 18, it is suggestive of compromised HPA axis. If it's more than 18, there is the normal HPA. So how do you do a ACTH stimulation test? So ACTH stimulation test is done using cosintropin. Cosintropin is now available in India as Sintropac. It is available from uh, Sun Pharma. So ACTH stimulation test is done using Sintropac. So what you do is give 250 microgram of ACTH intramuscular or IV and take a sample at 0, 30 and 60 minutes for cortisol, right? And what you do is then you need to, so you, in fact, you don't need to take a baseline sample, but this is generally not required, but you may take it. So you take a baseline sample and after okay, let me, so what you do is you take a baseline cortisol sample. This is sample 0. Okay, then you give ACTH, right, 250 microgram, either IM or IV. And then after that, you take a sample of cortisol at 30 minutes and 60 minutes, right? And you have to see the highest value. See the highest value. And if the highest value is more than 18, it rules out adrenal insufficiency. If both the values are less than 18, it is suggestive of adrenal insufficiency. So this is how you do a ACTH stimulation test, right? So again, I'll revise this point again, right? The stepwise process of diagnosis of adrenal insufficiency. So first thing you do a morning cortisol and DHEA-S. If the cortisol value is less than 5, it means HP axis is compromised. If it is 5 to 12, you do further, and more than 12, it rules out adrenal insufficiency in an outpatient setting, right? If it's DHEA-S, if it is value is between 5 to 12, you take a DHEA-S ratio. If the ratio is less than 1, it is suggestive of compromised HP axis. 1 to 1.8, you need to do a ACTH stimulation test, and more than 1.8, HP axis is considered normal, right? And if you have that in between situation, then you do a ACTH stimulation test, where if you have the cortisol post stimulation value is more than 18, it is suggestive of a normal HPA axis. Less than 18 is suggestive of compromised HPA axis. Okay, so I think this is should be clear, right? So I think this same thing again, right? So morning cortisol can be used for diagnosis. Less than 5, you have almost 100% specificity, but less sensitivity. Less than 3, so baseline value also there are debates, but generally 5 is considered a good cutoff, right? And upper limit is debatable for the adrenal insufficiency, right? Again, this is the area of debates. We'll not get into debates here. We'll basically try to keep things very clear. Okay, so we already discussed ACTH stimulation test. Now, first thing we did was to establish whether the patient is having adrenal insufficiency or not. Now, if you want to know whether this patient is having primary adrenal insufficiency or secondary or tertiary, why this is important? Because in primary adrenal insufficiency, you need to treat both the glucocorticoid as well as mineralocorticoids, whereas in a secondary or tertiary adrenal insufficiency, you just need to treat glucocorticoid deficiency, right? So to differentiate this, you need to measure the ACTH itself. So if the ACTH value is more than 100, it is suggestive of primary. If it is less than 20, it is suggestive of secondary or tertiary. If it is between 20 to 100, it is a gray zone, and this could be either primary or secondary or tertiary adrenal insufficiency. So if you had seen in the case earlier, the value was thousands. Often in primary adrenal insufficiency, the values will be very high, right? 500, 600, 1000, right? So typically that is suggestive of primary. If it's less than 20, it is definitely secondary or tertiary adrenal insufficiency. Okay. We already discussed about DHEA-S, and I told you this very important point. So DHEA-S is a very useful test for diagnosing adrenal insufficiency. And why this is important? Like I said, because it has a longer half-life, and hence it can be used to make a diagnosis early, right? Okay, so now let's come to the last part of today's talk, and that is management of adrenal insufficiency. So primary adrenal insufficiency, as we already discussed, you will require both mineralocorticoid as well as the glucocorticoid replacement. When a patient comes in an acute crisis, you start the patient on IV hydrocortisone, and high dose of hydrocortisone will have both the mineralocorticoid as well as glucocorticoid action. So when a patient comes in acute crisis, you start this patient on IV hydrocortisone. We typically give 100 milligram 8 hourly. Another protocol is 50 milligram 6 hourly. So these are two protocols which you can do in case of acute adrenal insufficiency. In chronic situation, you can give either oral hydrocortisone, which is available in India as Hyzon, or oral prednisone. If you're giving oral Hyzon, you need to give it in split doses. So typically we give 10 milligram at 8 a.m. and 5 milligram at 5 p.m. This is a typical dose which you give in terms of high zone. If you're giving a oral prednisolone, you can give once a day. So typically we start the patient on 5 milligram of oral prednisolone. Along with this, remember, you also have to give mineralocorticoid. So you need to give fludrocortisone, and typically we give 0.1 milligram, also 100 microgram of fludrocortisone typically. And in some cases, there is again an area of debate, but some cases DHEA supplementation is also useful, especially if you have young females. You can consider DHEA supplementation. Secondary adrenal insufficiency in acute situation, again, you similarly use cortisone. But in chronic cases, in this case, you don't have to give, you need not give mineralocorticoids. So you can give oral hydrocortisone, oral prednisolone, in some cases even dexamethasone, but generally dexamethasone is much more longer half-life, so patient may develop more side effects. So oral hydrocortisone, high zone, or oral prednisolone is generally what we prefer. Right. So this is treatment is, like I said, quite simple. So with this, we'll take some take-home messages. Right. Very importantly, when should you suspect adrenal insufficiency? So suspect adrenal insufficiency when you have unexplained weight loss, unexplained skin darkening, hyponatremia, hypotension, right? A baseline cortisol, which is very important, right? Less than 5, we discussed this in the new cutoffs, less than 5, right? 5 to 12 and more than 12, right? This is actually old take-home slides. So these are changed, right? So these are baseline values suggestive of, very useful. And then ACTH can be used to differentiate between primary and secondary, or primary, secondary, and tertiary. And DHEA-S is a very important emerging test for diagnosis of adrenal insufficiency. Again, this we had discussed last time also. If you have hypothyroidism with adrenal insufficiency, you need to treat adrenal insufficiency before you treat the hypothyroidism. It's important. Another important take-home message. A lot of these refer to endocrinologists, right? So that's the idea. So this is our notes in the endocrinology platform. So thank you for a patient listening. Sorry, we did not break for any questions in the middle, but if you have any questions, I'm sure if you put this question in the chat box. But we'll now be happy to take any questions. So you can unmute yourself and ask a question if you have. So once again, thank you for joining. I think I forgot to say this in the beginning. So thank you all for joining. And thank you for sticking on to it, and would be happy to take any questions. We have one question probably from, So one question from Dr. Purvi Chawla. Can you also address glucocorticoid induced adrenal insufficiency? Ma'am, I discussed this as the first case. In fact, discuss this. So when you have a patient on glucocorticoid being given steroids for a long period of time, you have what is known as a tertiary adrenal insufficiency. That is what develops. If you in case missed this section, we'll have the recording also available.